Good afternoon. Hi, I'm James Downey. I'm the CEO of the Independent Hospital Pricing Authority, and it's my pleasure to welcome you to our fourth and final Q&A webinar for 2021. Before we begin, I'd like to acknowledge the traditional custodians of the many lands on which we're meeting today around the country. For me, it's the Gadigal people of the Eora Nation here in Sydney, and recognise their continuing connection to land, water and culture. I pay respect to elders today and those who walk in spirit. So this Q&A webinar series is the first digital education program that we've launched here at IHACPA, and we've had three really excellent webinars to date, and I'm sure today will be no different. The aim of this series is to provide you with more information on the pricing and funding of public hospital services, and really to give you a chance to connect with experts in the field. And today we've got a fantastic panel of costing people online, which we'll introduce shortly. It's awesome to see that we've got over 300 people registered for today's webinar, and it's great to see so much interest in hospital costing, which of course underpins all the work we do at IHACPA in both pricing and classification development. We work really closely, as you know, with states and territories on costing, and we've worked really hard to improve the quality of the NHCDC over the last 10 years, as well as undertaking additional costing studies where we've needed to. Those improvements have included updates to the Australian Hospital Patient Costing Standards, which those who've been around for a while will know they've come a really long way over the last 12 years since the first set were hammered out in as those who can remember, very, very long meetings in Canberra over about an 18-month period. So in this session, you'll have an opportunity to ask questions about costing, including the collection, validation, analysis and reporting of costing data from IHACPA's team. And we've also got Liz and Colin from Queensland who will be able to give a state perspective. I hope you find this session valuable, and I hope that you've had a chance to join our other three webinars. If you've missed them, of course, the recordings are available on our YouTube channel. Our moderators for today is Dr. Sarah Neville. She doesn't need a whole lot of introduction. She's our Director of Analytics, but you've seen her at a couple of other sessions. And she's also the 2021-22 Harkness Fellow in Healthcare Policy and Practice. So we'll be heading to the US in 2022 to take up that role. Dr. Neville is a statistician with a strong interest in health research and leadership. She's been working in the Australian health system for 7 years, including setting the price for hospital services to make hospital funding more transparent and equitable. Prior to this, Dr. Neville completed a PhD in mathematical statistics, and her interests lie in health funding system, Bayesian statistics, and women in STEM leadership. So if you've got any questions about the middle one, feel free to fire away. Sarah is also passionate about the power of statistics to inform evidence-based policy, both in Australia and internationally. So I hope you really enjoyed today's session, and we'll look forward to you joining us again in February 2022 when the series returns on with data collection. And I just want to wish you all a very safe and happy Christmas and New Year period. And over to you, Sarah. Thanks.
Thanks, James, and good afternoon, everyone. Welcome to today's session, insight into patient costing data, the interplay between the standards, the National Hospital Cost Data Collection, or the NHCDC as we refer to it here at IHACPA, and improved accuracy in pricing. Further to James's introduction, the NHCDC and IHACPA's hospital costing processes, there's an introductory video available to view on IHACPA's YouTube channel, which provides some really good additional background to the cost collection, and also some really good examples. I'm going to start by introducing our panelists. Thanks very much for joining us today. And if each of you could just raise your hand as I introduce you, just so anyone who doesn't know you can get familiar. So joining us today from the IHACPA side is Julia Hume. She is the Independent Hospital Pricing Authority's Executive Director of Data Analytics. Julia leads the teams responsible for the functions of costing, pricing, data acquisition, IT infrastructure, and My Team Analytics at IHACPA. Julia has worked extensively on the NHCDC for both the public and private sectors. She holds a degree in applied science, in particular health information management, and a master's in political economics from Sydney University. She's previously held roles across the health sector, including working in health insurance and cancer research, and Julia has also worked in the international development sector in several post-conflict countries. That helps us out in some of our advisory committees now and then. She's pretty difficult to intimidate. Welcome, Julia. Our next panellist from the IHACPA side is Iman Mehdi, who is the Director of Hospital Costing at IHACPA. Iman leads the team delivering IHACPA's costing projects, including the annual NHCDC submission, the Australian Hospital Patient Costing Standards, which we'll refer to as the standards from now on because it's a bit of a mouthful, and the Independent Financial Review and Costing Studies. Iman works closely with the jurisdictions, including Liz and Colin, who I'll introduce next, during all of the processes associated with costing data every year to refine and improve the standards, the collection structure, and also the reporting tools. Iman is bilingual and multi-skilled with almost 20 years of broad experience in the public service. Her expertise spans diverse areas including business management, fraud and investigation, procurement, contract management and finance, previously managing the finances for the Community Development Employment Projects. Welcome, Iman. Joining us remotely from Queensland are Liz Lee and Colin McCrow. And Colin was a late addition, so I don't have a detailed bio for Colin, but he is the manager of activity and costing, and he's well on his way to becoming a national treasure in the costing side of things. Liz is the Director of Funding and Costing, Healthcare Purchasing and System Performance at the Queensland Department of Health. Liz is responsible for providing high-level strategic leadership, professional support and expert advice in matters relating to activity-based funding at a state and national level, developing innovative approaches to better align funding allocations with value and patient-focused outcome measures, no mean feat there, activity-based costing functions and counting and classification. Liz has over 20 years of experience working in clinical costing and ABF roles as a system manager within metro, regional and remote local hospital networks. Welcome, Liz and Colin. All right, so thank you all, our very valued panellists, for bringing your expertise and perspectives to the panel. I'm looking forward to directing the audience's questions to each of you today. Now for some quick housekeeping. To submit questions to our panellists, please click the live Q&A tab at the right side of your screen. You can read other submitted questions and vote for those you would like answered, and your questions can be technical as is required for your role. I'll direct your questions to the most appropriate panellist to answer, and we'll do our best to get through as many questions as possible. All right. Registrants were able to submit questions in advance, which we'll begin the discussion with, just because things can take a little while to get rolling. And I'd like to direct the first question to Julia. So what do we have for Julia?
Hi, Sarah.
Hi. So just to kick us off, can you provide an example of where we see variability in cost data and the drivers of this variability?
Yeah, okay, thank you. So I suppose it's important to remember that IHACPA receives the National Hospital Cost Data Collection after it's been prepared by hospitals or local health districts, and then jurisdictions have also reviewed and added to that data as well. And so what we receive as that collection has been through several sets of hands and hopefully been used for several different purposes along the way before IHACPA create the national data set, which we use for a number of items, but often we talk about how we use it in the national efficient price. I will say at once, the Australian Hospital Patient Costing Standards, version 4, are the current version of the standards that we, IHACPA, have developed with jurisdictions, which guide the costing process. So while they are designed to have consistency in the approach to costing, we know that jurisdictions apply them differently, and depending on what information systems are available at the hospital level, that can also impact how the standards are applied. We try and encourage hospitals and jurisdictions to be practical in their approach. We know that general ledgers are structured differently. Costing systems can vary across the country as well. So there's some sort of structural variation in what we see in how the standards are applied and the underlying feeder systems, which influence that. But then there's also quite a bit of interpretation of the standards as well that happens at the hospital level. And so we can see that coming through at the cost data in the NHCDC.
Awesome. Thanks, Julia. We might move across to Queensland briefly. So I'll pose this one to Liz, but of course we've got Colin there as well. How can costing data be used at the local hospital network level, or HHS in Queensland, to improve efficiency and management?
Thanks, Sarah. I think one of the unique characteristics that we have of the clinical costing data is it's one of the that has information from a multitude of different clinical data sources. So we're getting information from our pathology systems, from our medical imaging, from our pharmacy, from our wards units, throughout many different areas of the hospital and health service. And what we do is we bring it all together and we consolidate that information, which enables us to provide the clinical costing outputs and a profile of what's actually happening to the individual patients whilst they're receiving care in our facilities. And what that does is it allows us to utilise that information to look for opportunities and to look for variations in clinical practice and ordering patterns and things that are happening within the one facility, across multiple facilities, within the different diagnoses and the classifications that the patients are falling. So it does have that unique ability to bring all the information together and enable us to report on what's happening and have a look at it from many different perspectives.
Yeah, great. Thanks, Liz. And then I'll throw to Aman quickly, just to give a brief answer to the question, what are the key differences between the public and private NHCDC rounds?
Hi, Sarah. The differences between the public and the private sector, like the key differences are, first, the scope of the private sector is different. The scope of the private sector and HCDC is limited to acute only, but recently in round 23, this was expanded to include subacute and mental health, and where the public sector is all stream from admitted acute to subacute mental health and admitted in emergency departments. The other key difference is the private sector is a commercially sensitive data, so therefore IHACPA, or we don't publish actual cost in the report, and we publish cost weight, and this is just due to the sensitivity of the data. Also, the outputs or the participation of the private sector as well. It's the incentive of the private sector is also probably just for the costed outputs, where we publish, a report, but we also provide hospital all participating hospital a hospital report which benchmark to their own hospital to their national costs, where the public sector is the incentive is for funding. So, and also the some of the costs that present in the private sector is not really comparable to the public sector, because like such as, for example, the majority of the private hospital do not provide like services directly to patients, such as like the pathology costs, medical specialists, and that the patients actually pay for this directly to the services that provide, you know, directly to the services that provide this type of services. So there are a few differences between the public and the private sector.
Great, thanks, Iman. So we've started getting some questions through from the audience, which is excellent. I would encourage other people in the audience to start sending you questions through. It doesn't matter how technical they are or how high level, happy to field them all. But what I will start with, and I'm actually going to pose this to our IHACPA staff, but also our jurisdictional representatives, Queensland. And this comes from Michael Reynolds, who's already sent a couple of questions through. So thanks, Michael, for that engagement. I'll throw it to Julia and Iman first. So it's all about how and which clinical groups has IHACPA worked with in creating greater understanding of the value of the costing data sets. So I'm going to ask the IHACPA team that one first, but then probably interesting to get a state perspective on how clinicians are engaged in the costing process as well. So I'll start off with IHACPA.
So IHACPA have a clinical advisory committee, which we work with on, you know, all of our work program, and we also engage them and share with them the outputs of the National Hospital Cost Data Collection. And in particular, when we are preparing the National Efficient Price, how variation in cost can, the impact of that on the NEP and around different adjustments and that we make there. When it comes to working with clinicians in hospitals, IHACPA is, I suppose, one step removed from those facilities, and I suppose this is where I'd throw over to Liz and Colin.
Yeah, I think that's a good opportunity to segue.
Sarah, thanks, guys. I think it really depends on the individual hospital and health service. Some have very proactive clinicians who are very passionate towards costing, who are very familiar with the concepts behind costing, and who will actually seek out the costing teams and will actively engage with them. In other hospital and health services, it's not as much of a priority. What we're trying to do from a state side is to speak and to engage with the ones that have achieved this successfully and look to applying those learnings across the broader hospital and health services. I think the profile of costing has increased a lot in recent years. Once upon a time, the costing team sort of lived in the basement with medical records and, you know, really didn't do much other than maintaining the system. Whereas now people are expecting the information, they're seeking it out, they are looking for ways to improve services and to look for those efficiencies and those opportunities. So it's not something, I mean, we certainly don't have the magic answer in relation to that. I think it's an ongoing journey, and it's all about continuous improvement in that area. But I think really looking for the champions and being able to find them within the individual areas, and also trying to disseminate the information a lot more and make it timely and make it meaningful. So getting that input back from people about what they are looking for, what's helpful to them when they are managing a service, and trying to customise that approach.
Yeah, I'll just also just to add to that too. So on a jurisdictional level, we've done a number of projects with our clinical networks. So we've been involved with renal networks. So there's a lot of work that's been done with renal network. We've also worked with some of the other clinical networks, normally in response to specific clinical practices, looking at understanding clinical practice variation across the whole jurisdiction, and looking at different cost outcomes. So when they're getting different cost outcomes, should they be looking at changes in clinical practice and standardising clinical practice? That's a question that's come up a lot, probably in the last 5 years. And then, as Liz said earlier on, it's about finding those clinical champions. And I think the impact of the costing from a clinician's perspective is not what it costs, but how I can improve my basis for improving patient outcomes within a limited budget. And so those clinicians that are being asked the questions from their financial teams about managing their budget are more prone to ask questions about understanding the costs and the flows and how they can improve that situation. Whereas if they're not approached by their financial team with those questions, and in some places the financial team work with the business managers, not with the clinicians. And so you can get a little bit of a disconnect between the business side of the hospital and the clinical side of the hospital, but where that connection is happening, and it's usually where there's confidence in the data, confidence in the output of the data, and people are seeing that it's making a difference. That's where you start to get the better clinical engagement. But it needs to come from both sides of the hospital, both business and the clinical side.
Yeah, and it sort of takes them meeting in the middle to really utilise the power of the cost data, because we're one of those really rare examples internationally where we do have patient level cost data, which is, I think we can forget that because we're quite used to it. But when you do look internationally, people can't believe the fact that we have such wide coverage of patient level cost data in our public system. So it's something we can be really proud of, that's for sure. All right, I'm going to ask another question that's come through live. So I might ask Julia this one. This one also comes from Michael Reynolds, but we've also got a couple more people sending questions through. So I'm going to continuing encouragement of people putting those questions through. What of private patients in public hospitals? Are input costs captured separately? And if so, where are they reported?
Hi, so in our NHCDC collection, we collect all costs for patients regardless of their public or private status. And the costs that we collect are at the cost centre and line item level. So, for example, it could be, physiotherapy or ICU as the cost centre, or allied health. And then the different line items might be salaries and wages or goods and services. And regardless of the patient being public or private, we have an expectation that all costs relevant to their episode of care are included in that submission. We know that there's different billing practices for private patients when it comes to medical fees, and also around some private health insurance payments. Those different ways of dollars coming into the general ledger, I suppose costing is agnostic of that. What we're interested in is how much it costs to treat that patient at that point in time. Later on, when IHACPA is using that data, we work with jurisdictions to understand if all costs have been included or not, and have developed an approach which is consistent when we're using the NHCDC data.
Yeah, that's often the challenge with the NHCDC. It does have many purposes, but a big one is forming the basis of the national efficient price each year. So here at IHACPA, trying to get that national consistency across a raft of states and territories can be quite challenging. Do you have anything to add on the private patient in public hospitals question?
We could only add, Sarah, what Julia said. We cost agnostically to the service. So the fact of a patient being private within a public hospital, we do get some indicators within our data sets. So for instance, with our pathology system, we differentiate between what is publicly billed pathology tests and what are privately billed, so we can make sure that the costs are flowing through correctly if there is any reimbursement that is occurring, so the hospital isn't incurring the charges for those individuals. But all in all, we use the classifications to identify the patient, and then we will cost them based on the services that they have.
Yeah, just further on that, the difference nationally is really around how different providers are paid and what's actually going into the hospital ledger. So we follow the principle of the standards, and that is to cost all your expenses that you have in your ledger. Then you'll reflect the cost to the hospital, because if you make costing funding system or funding provider agnostic, if your funder provider changes, you know what the cost of the service is. And I think that's one of the key important components to consider. One of the reasons that we have not to offset revenue as part of the principles of the standard is if you offset your cost with revenue, you don't actually understand the cost of the service delivery. And that's really, really critical. So when you start to compare those patient level costs across jurisdictions, there will be differences simply because of what's actually sitting in the ledger. And that's an important thing to remember when you start to look at benchmarking between jurisdictions. The cost variance with their private patients may be significant in some areas, depending on what's actually hitting the hospital ledger. Now, that's correct for the jurisdiction that you're actually looking at. And so I would be suggesting that when people start to look at benchmarking data, look at your public patients first and look at the benchmark variances between your public patients, and that can be a guide for then also looking at what those costs are with the private patients, realising that it's not going to be the same between all jurisdictions, specifically around medical costs and also around things that are privately billed to patients with NBS and PBS. They're probably the three areas of variance between each of the jurisdictions. But the underlying data, the cost of providing the care to the patient who's in that bed, from the nursing staff and from all the other staff, including the junior medical staff that work with those visiting medical officers and senior medical officers and consultants, doesn't change regardless of whether the patient is private or public.
Great, thanks for that, Colin. That's some really good insight. Just had a question through from Stephen Theng. The latest NHCDC report is on 2018-19 data, the round 23 collection. And Stephen's interested in knowing when the new report on the new data will be available.
Yeah, thanks for that. It has been drafted. We received the 2019-2020 data set earlier this year. As you could imagine, it was a year where we started to see the impacts of the COVID pandemic in the last quarter of that year, which resulted in both challenges for hospitals, jurisdictions, and IHACPA when it came to collecting that data. The report has been drafted, and I expect it will be on IHACPA's website by March.
Thanks, Julia. So just touching on that that sort of thread, and also something that Colin mentioned earlier about sort of how robust the data is and trust in the data, particularly from the clinical side of hospitals. People often ask about the quality of the cost data. So what I think would be interesting for the audience is to get an idea of the processes involved with validation of the cost data at the jurisdictional level. So Colin, I might pose that one to you, and then I'll follow up with Aman on additional validation that we do on the national data set.
Okay, so there's a significant amount of checks and balances that are undertaken on a jurisdictional level. I've been lucky enough to be involved in the independent financial review as a peer reviewer in all of the states around Australia. And I know that in each jurisdiction, while some of the input processes, etc., are different, the number of validations that they run over the data before submission are significant. Most of the jurisdictions a few years ago adopted the validation measures that are used by IHACPA when the data is presented to the IHACPA portal, and a lot of jurisdictions actually are running that code set over their data to check for those types of errors. Because if you have those errors, for example, if you've got a total negative cost episode, obviously in a funding model, if you are getting a whole lot of negative cost episodes, and there are reasons, valid reasons, that you can get negative cost episodes that do occur for one reason or another, they will not load into the portal because you can't have a negative cost in your funding model. You can only have positive costs. So both the costing system tools that are available, and also through using SAS and SQL code, you can go through and identify those particular episodes that have data quality issues. The tests that we run here in Queensland, I think there's about 300 of them, but we're looking at the low-level data elements to identify the errors that may occur, and errors do occur. We're talking about very, very large data sets, and you can have one particular component that will impact multiple other components. So they're the things that we have a look for, and the aim from each of the jurisdictions is to ensure that when we submit the data, it is as clean as it can be from the national data set. I think we do have quality data across the country. That doesn't say that there aren't any data quality issues that occur. There certainly are, and that does occur. But I think what we submit to IHACPA, approved and received by IHACPA after all of those portal validations, is a data set that is robust and suitable for funding. And yeah.
All right, I'll throw over to Aman to then sort of, once we get the submission from states and territories, what additional validation we do in order to ensure a good quality national data set.
So there are a number of quality assurance that we or IHACPA undertakes when we receive the data. So the first to start with, we do provide our data request specification to jurisdictions before each round. And then the jurisdictions will need to submit the data in accordance with the DRS. The second is when the jurisdictions submit the data through the IHACPA data portal, and the data gets validated automatically, and it should pass with no critical errors, as Colin just mentioned. And when the jurisdiction provide the data, then IHACPA undertake an ETL process, which is extra transform load, where we group the data into the cost line, into the line item, and cost centers into a cost bucket matrix, where it detailed all the cost and the type of services for such as the as well imaging, pathology, salary and wages, so all the data is grouped into the cost bucket matrix. So when we finish from the ETL process, then IHACPA prepare quality assurance reports for jurisdictions. We prepare a national national report, and then we also prepare a quality assurance report for each participating hospitals, where this is provided to jurisdictions to review the data and ensure that the data submitted is reflected in the QA reports. And based on these QA reports, the jurisdictions confirm to IHACPA that. And also another QA we do on the data and HCDC, which is, it's an annual review of the independent financial review, where all jurisdictions participate in the review. And this is to look at the first, if the data submitted to IHACPA is in accordance with the Australian hospital patient costing standards. And also that, the jurisdictions include the complete cost and activity in their submissions. And doing that is we review samples of sites or hospital sites across the Australia, like sites for each jurisdictions, where their sample should be like representative. And we look and the review look at the data flow from hospital to jurisdictions, and then from jurisdictions to IHACPA. If there's any adjustments, any exclusion, inclusion in the data, and that should be all reported and explained. And if there's any variances as well of what we receive from the jurisdictions, that will be also explained. And also the last one, which is a formal QA, is the data quality statements, where the jurisdictions submit or provide a signed document, data quality statements, where they confirm that their data is in accordance with the standards. And also if there's any issues with the data, or if there's any new hospitals, if any feeder system, any system that they use for that year, that's also explained in the data quality statements. And those data quality statements are published on IHACPA's website along the cost report.
Great, thanks, Simone. And the IFR is published as well, isn't it?
Yeah, and the IFR is published. Yeah. So for round 23, due to COVID, impact of COVID-19 on health services and jurisdictions, so it was cancelled. However, we have the round 24 IFR, and that will be published similar to the round 24 report, public hospital report, in March.
Great. Thanks very much, Colin and Aman, for that very robust overview of the validation of the NHCDC. I think the quality of the data has definitely been improving over the last, 24 rounds, but it's definitely a matter of continuous improvement. There's always improvements to be made. So thanks very much for that overview. We've got a couple more questions from the audience. I'm going to go with Cole Roberts, one of our friends from Darling Downs. His question is, many of our NEP, National Efficient Price variations at a DRG level, are from components such as blood products. As a health service, our expenses include these, but IHACPA considers these to be Commonwealth funded, along with things such as PBS. Can blood component costs be identified by DRG by IHACPA as well?
Hi, I'll answer that. Yes, we do see blood costs come through. There's a designated line item for those. Not all jurisdictions submit those costs because it's a line item when we publish so in the cost report, it can be seen. There's a table around line items. When we look at the DRG reporting, those costs have been included in a cost bucket. Once, when we're using that data for pricing, we have a process to exclude blood costs because they aren't funded through the NHRA.
Great, thank you, Julia.
If you're interested in them, send us an email out of session.
There you go, Cole. You've got agreement from the Executive Director of Data Analytics. Yes, we can.
Just send an email.
Yeah. All right. Question through from Kees Van Gool. Following up on the discussion of private patients in public hospitals, has there been any like-with-like analysis of public versus private patient costs? I might ask this of Queensland first up to see if there's been any of that done in your jurisdiction, and then I'll throw back to IHACPA.
Sarah, probably a quick disclaimer. As with all good webinars and presentations, we've just had the fire announcement. So if we cut out in a second, we'll go back on mute so you don't hear the fire alarm testing.
Thank you for the heads up.
Isn't it? Yep. Excellent. Absolutely. you know, as we mentioned before, I mean, although the patients are agnostic for costing, I mean, there is different revenue that come in for these individuals. So that's certainly something that hospital and health services will review and will monitor, and also look for how, although Colin said we don't incorporate revenue into costing, we do compare the cost of patients based on the NWOW revenue and the actual cost of those individuals as well.
And the other thing too is with the increased use of contracted services, we have cost data flowing into our health services that are having contracted services undertaken for them within the private sector. And so those costs are coming through, and most of that now we are getting through at patient level. So if they're providing a partial service like a particular diagnostic test, that's coming through at the individual patient level. If they're providing a whole of a service, which might be operating theatre, or it might be the whole of the care of the patient, but it's being on charge, we're getting that information come through now. And that's improved a lot in the last probably 4 to 5 years. So we can start to compare that information. I think that doesn't quite answer the question though. The question is, are we looking at the cost of an equivalent patient cared fully in the private system versus a private patient in the public system? That is a lot more problematic, because you would then need to have that cost information from the private system in order to be able to do that. So that's probably something we can't do in the jurisdiction, as I say, unless it's a contracted service, because we don't have access to that information.
Thanks, Colin. Julia, anything you'd like to add from the national perspective?
No. Yeah, generally when we report on the public sector collection, I think we used to possibly have a table in the cost report where we were looking at public versus private patients in public hospitals. But no, we don't publish anything on that routinely.
Okay, thanks, Julia. Interesting questions come through from Ian Wright. Bit of a long one, so bear with me. Johns Hopkins Aramco Healthcare in Saudi Arabia has recently, so in October just gone, turned on a costing system. It has coded to the Australian costing standards and has 2019, 2020 and 2021 costing data. Where would you look to first improve data quality and accuracy? And how would you proceed to continually improve data collection? I think they're looking for some low-hanging fruit here.
If I may, the first thing I think I would just look at, if you've got 3 years of data in there, if I can be as crude as saying, look at the top 10 DRGs by volume and then compare them across years. Like, I think it's fantastic to have, and there's great value in that longitudinal data set. Variation might be because costing has improved, or so that could be a good thing, or it might mean that there's been an error in how the data's been included. So large changes could be good or could be not so good. But they're worth having, asking another round of why has that changed. I suppose I'd say.
Yeah, good insights, Julia. Anything from Liz and Colin?
Just add on that, I think as a part of your quality process, you want to have a look at your cost outcomes between years. We run ours over 5 years and look at 5 years worth of data, and we look at all DRGs. We don't do top 10. A cost rate report is very easy to produce. So what you're looking for is cost variability at average costs, differences in average length of stay, and also looking at differences between your major cost components, particularly your salaries and wages components. I would suggest that you want to have a look at salaries and wages at line item level rather than cost bucket level, unless you want to look at things like operating services and critical care separately. The other thing to look at is the completeness of your data. So are you getting only inpatient data? Are you getting data across the continuum? So you're looking at your outpatients, you're looking at your EDs, starting to have a look at your flow of your patients through the system. So most systems you will have a common patient identifier. So if you have a common patient identifier, you can start to have a look at where the patient has presented to the health service, and then you can then have a look at that pattern of flow. In every implementation of the costing system, you will always find black holes, data where you don't have patient level information. So the next thing to do is to say, to analyse what you don't have. What was the information that I don't have? That's really important. Do you have all of the costs flowing in from your ledger? So do you have a significant amount of your costs that are sitting outside of your ledger? So some places may have a different ledger for certain particular purposes. So are you capturing all of that cost? Is there any revenue being offset? And in some countries around the world, offsetting revenue is actually part of their standards. That's an expected component. So it's about understanding your financial environment as well as understanding your clinical environment.
Thanks, Colin. Some really good insights from both Julia and Colin around, lessons that they've learned from being in the costing world. And just, when you're setting up a completely new system, it's great that you have 3 years of costing data and being able to take that longitudinal approach. But some really good insights there, so thank you both. We've got a few more questions flowing through, so thanks very much to our audience again. Some quite topical questions. I don't think we could have had a webinar about hospital costs without reference to COVID. So I will throw this one to Julia. Will the impact of COVID-19 be considered in the cost of providing healthcare services? For example, and we have seen this, during COVID there were higher costs and less services delivered. How will COVID factors be included or excluded in IHACPA's determination?
Thanks, Sarah.
Bit of a curly one.
Yeah, so I suppose, yes, we at IHACPA have worked a lot over the past 6 months to try and understand the cost of providing healthcare services, in the COVID pandemic period. There's been many challenges with it, and I think that one of the largest, one of those is that the period of cost data that we have is the 2019-20 year, and it was only the last 4 months of that year which were impacted by the pandemic, and I think that was a very different impact in that year to what we have now and what we'll be having again in 2022. So there's two different impacts. I think there's the will the provision of healthcare services change in the medium term, like the next 3 years, as well as during peak and sort of acute pandemic periods, how have those things been changed? So yes, we have and we will continue to look at that, and it will be reflected in determinations when they're published.
Yeah, it's been a huge part of IHACPA's work program in the last 6 months or so. Question for Liz, and it links into part of how I introduced you in your bio, and it's all about how cost data can be used in developing potential value-based approaches in the activity-based funding space.
Thanks, Sarah. As I mentioned earlier, we do have the opportunity to have all of this data centrally available. So one of the areas that we have looked at before is ordering patterns. I did a presentation a while ago and we were looking at an individual patient that was having multiple blood tests on consecutive days, which when speaking with clinical staff, we couldn't really see why that would have been occurring for that individual. So I think it gives to interrogate the data more and to look at what the patient is coded with and how that might relate to what the ordering patterns are. One of the areas that we acknowledge that we do need to expand within Queensland is our capture of the patient-reported outcome measures and the patient-reported experience measures, so the PREMs and the PROMs. There's a number of projects going on within Queensland to try and capture that information, and that actually will be very, very powerful when we can integrate that into costing and we can actually see beyond just the interventions that we are providing what that is actually, what the result is from the patient's perspective, and that's when value really will be enabled and we will be able to do some important reporting in relation to that.
Yeah, and just on that too, the other thing that we're looking at is where services are delivered as compared to where the person is physically located, so using SA2s for that kind of profile of the total care that's been provided. Just one other comment though, I think when you start to having a look at value-based services, value-based purchasing, lots of other different names around that, jurisdictions and hospitals have the level of data granularity to do that. Currently, nationally, we don't. So by the time it goes to the NHCDC, you've lost that level of granularity in order to be able to do any analysis nationally. So, and I think as this is a growth area, it's an area that needs to occur first at the hospital level with the actual collection of data and the aggregation level first before we could even start to consider doing anything nationally with those kind of questions. And I'm sure there are national questions that are being asked, but that's a case of the size of the NHCDC in order to be able to do that would increase exponentially.
Yeah. Probably just to also add, probably just
over to you.
It's not, sorry, although it's not specifically related, a lot of improvements in years with it at the national level in safety measures. So we've had the hospital-acquired complications. We've also had the avoidable hospital readmissions. Queensland has actively rolled that out to our hospital and health services.
Yep.
So any adjustments that are required at a state level are flowed through to the individual hospitals. So they're very acutely aware of those type of quality measures that are available now. We've also expanded them sometimes from the national level. So initially, where the indicator may have only been applicable for, say, acute and mental health patients or patients in ABF facilities, we've actually applied it to all admitted patient cohorts and across our ABF and our non-ABF hospitals as well. So we're looking at what data is available. Also as well, the introduction of the individual healthcare identifier will allow us to do a lot more in this space, because we'll actually be able to identify an individual across multiple facilities that they are receiving care in. And again, not related to costing, but we are looking at other more value-based mechanisms for pricing those individuals. So looking at capitation models, looking at bundled funding, because that will encourage improvements and encourage value rather than just, you know, a count of how many people walk through the door and how many episodes we've provided.
Yeah, it's about making the funding model fit. You know, there are some areas in clinical service delivery that don't fit neatly into Model A or Model B. And it's coming about understanding your service delivery and also how you can improve the care for the patient, because that's really what we're here for.
Absolutely.
Yeah, and designing pricing and funding models that don't interfere with those models of care in particular. And yeah, we're also considering those more value-based approaches at the national level from IHACPA's perspective. You mentioned capitation and bundling. Liz, and that is challenging at the national level because we don't have a lot of the great data that we would love to have in the national collections, but we also recognise that it takes a hell of a lot of work to get national consistency, particularly if we're looking at something as complex as PROMs and PREMs. But it's also important to remember the things we have done in terms of the hospital-acquired complications funding adjustment, the avoidable hospital readmissions funding adjustment, where we use that outcomes data in conjunction with the patient-level costing data in order to actually implement these value-based approaches. So I think we've taken some really important steps in the right direction in terms of value-based care, but still a lot of opportunities to do more. And I think that's going to depend on IHACPA engaging with states and territories to do pilots with particular local hospital networks in particular areas of care. And I think that's something that we'll see develop more in the next 12 months or so, once we've dealt with this little COVID issue. All right, we've got about 4 minutes to go, so I am just going to scan over to see if any last minute questions have come through. Just have a look for the value-based thing. I might just throw to the IHACPA team. I think this might relate to new health technologies framework. How does IHACPA handle the cost of a new surgical intervention without a pre-existing DRG?
Yeah, hi. So I think there's two issues there. One of them could be whether it's actually new technology or a new high cost therapy or treatment, and there's particular processes under the National Health Reform Agreement in how IHACPA include those in the national efficient price and national efficient cost. In relation to new surgical interventions without a pre-existing DRG, there have been cases where new DRGs can be created, but generally all activity will end up in a DRG. And if we start to see in our DRG review process and refinement processes that there's greater distribution of costs or bimodal type cost distributions, or there's through clinical consultation, it's determined that the DRG should be split based on the diagnosis and procedure codes, then we can do that through our DRG refinement processes.
Fantastic. Thanks, Julia. Short and sweet, very important. All right, well, look, it's 12:58, so that's all we have time for today, unfortunately. I feel like we could go on for another hour. But thanks very much for joining us this afternoon, and I'd like to personally thank each of our panellists. It's been a really great session. It absolutely flew by. For the attendees, I'd ask that you please stay online for a moment, as a short survey will appear on your screen, and we would really appreciate your feedback on the session. The next session in the educational series is scheduled for February 2022. To find out more, including the upcoming session topics and dates, head to our website, ihpa.gov.au/events. And we look forward to seeing you at the next IHACPA event very soon. Thanks, everyone.
Thanks, Sarah.